video is about Prism adaptation test, which is an essential armaneterium for strabismologists. This video demonstrates the basic principles of Prism adaptation test and its uses in management of acute onset esotropias and intermittent exotropia. This video discusses the use of Prism adaptation in horizontal strabismus with distance near disparity and concomitant strabismus. So why and where Prism adaptation test is done and needed? It is done to improve the binocular single vision after surgery and to estimate the potential angle of deviation which could give diplopia-free field postoperatively. So it is most commonly used in acute onset esotropias, in intermittent exotropia, in concomitant strabismus, and in restrictive strabismus like DRS. The use of Prism adaptation in horizontal strabismus is done in distance near disparity and in concomitant strabismus. PAT enhances surgical performance and success rate of strabismus surgery. So strabismus surgeons should be aware of when to use PAT for titrating surgical dosage and when to avoid it. The goal of PAT is to measure the full deviation and to assess the possibility of binocularity achievement after surgery. It offsets the deviation and present feasible stimuli. Therefore, an understanding of physiology of binocularity is essential to correct estimating the results of sensory-motor testing using PAT. A short PAT with an endpoint of motor stability in patients with acquired non-accommodative esotropia is associated with good surgical outcome with low rate of over and undercorrection. PAT may be unnecessary for patients with an angle of deviation more than 40 prism diopter. So what is the mechanism of action? AIOC prism are placed in front of both the eyes and then the subject makes motor response. And we have to measure how quickly the adaptation occurs. And then prisms are taken off to measure the after effect. PAT is useful to predict the outcomes of surgery and reveals whether the changes are going to happen in binocular single vision post-surgically. And it is mostly used for acquired esodeviation. Now to understand how the PAT works, we need to first understand the Burgess adaptation. There's a fast fusional vergences, which is a burst movement that moves the eye to correct vergence position and minimizes the difference between the vergence of eyes and target. And then there's a slow fusional vergence response to the effort put by fast fusional vergence and sustains vergent position of the eyes over a long period of time. Thus, PAT is the summation of both the fast fusional vergence and slow fusional vergence. So what are the prerequisites for PAT? Patient should have equal or near visual acuity. Angle of deviation should not be large. They should have approximately near and distance deviation, and there should be a stable angle with very minimal vertical component. This video shows how a PAT is done for near and distance. So in this particular patient of acute onset esotropia, Fresnel prism are placed in both the eyes with the base out and apex in, and patient is then asked to see the near and distance target with the alternate cover test. And in this test, we can see that there is no deviation of the eye. So this PAT can be done for half an hour, 45 minutes, 1 hour, or some people do it for around 24 hours also. So in this patient, we are checking the binocular single vision with red 4 dot test. And as you can see, along with the Fresnel prism, the red and green glasses are placed, and then patient is asked to see the worth 4 dot distance at distance and at near. And in near, he is able to see the 3 circle, which shows that there is VSV present at near. And similarly with GNO test, he is able to read maximum number of plates, which tells that after PAT, there is possibility of recovery of both the binocular single vision and stereopsis. The another video shows similar thing, that after PAT for 1 hour, the patient is able to see 3 circles which tells that patient is having binocular single vision for near, and again with this plate testing, patient is able to see the small and red circle, which shows that some amount of stereopsis can be achieved after Prism adaptation test. So applying these into acute onset esotropia in this particular patient part with 30 Prism diopter with BSV at near and distance, it was present after 40 minutes. And so the left hypot of 5 international units were given to MR muscle, and postoperatively patient had good BSV with no diplopia. In this patient of acute onset esotropia, after PAT, 40 Prism diopter of angle was measured after 1 hour. So patient underwent 6 mm of MR resection with adjustable suture along with 7.5 LR resection. In this case of DRS, patient underwent Brooks modification with superior rectus transposition to the lateral rectus with intermuscular augmentation and MR recession of 6 mm. Pre-op, there was a part of 35 Prism diopter with no face turn. BSV was present for near and distance with no diplopia. So the target angle was 35 Prism diopter. So there are various studies which shows that PAT is used in the surgical management of acquired esotropia mainly and less commonly in IXD. Thus, PAT enhances surgical performance and success rate of strabismus surgery. This meticulous planning case by case can help in giving the good result. Thank you.